Well, it's freezing cold outside, cloudy and flu season, and thus it is my pleasure to welcome you to Southwestern University and to Healing, the Art and Science of Medicine, our 36th annual Brown Symposium. The Brown Symposium series is funded through an endowment established by the Brown Foundation of Houston for named faculty chairs at the university. Its purpose is to enhance the scholarly work and to enrich the scholarly conversation on the Southwestern campus, the oldest university in the great state of Texas. And by the way, yesterday we celebrated our birthday, 174 years young. Thank you. This year, our Brown Chair Symposium coordinator is Dr. Benjamin Pierce, professor of biology and holder of the Lillian Nelson Pratt Chair. Dr. Pierce has invited some of the world's finest scholars to Southwestern, and over the next 2 days, we will all have the wonderful opportunity to share in their knowledge and expertise. I would like to take a moment to briefly introduce our distinguished symposium invited guests who are joining us here today. They are Kevin Davies, Vice President of Business Development for the American Chemical Society Publications. Dr. Davies holds a PhD in molecular genetics and is the author of several best-selling books, including The $1,000 Genome, in which he discusses how low-cost DNA sequencing will transform the practice of medicine. Dr. Mauro Ferrari, engineer, mathematician, Ernest Cockrell Jr. Distinguished Endowed Chair, and President and CEO of the Methodist Hospital Research Institute in Houston. The author of hundreds of important scientific publications, he is one of the world's leading authorities of nanotechnology in medicine. Dr. Peter Hotez, Dean of the National School of Tropical Medicine and President of the Sabin Vaccine Institute. He is the author of Forgotten People, Forgotten Diseases, and is a leading expert in the field of global health. Dr. Jonathan Skinner, the James O. Friedman Presidential Professor of Economics at Dartmouth College. He is also Professor of Family and Community Health at the Giselle School of Medicine and an expert on health care economics. Dr. Victoria Sweet, Clinical Professor of Medicine at the University of California, San Francisco School of Medicine. She is a physician, historian, and author of the best-selling book, God's Hotel. Dr. Sweet holds an MD degree as well as a PhD in the history of science. Ms. Ann West, an undergraduate student at Wellesley College. While in high school, Ms. West became interested in her family's genetic history and how it might influence her own health. She collaborated with a group of researchers who sequenced the genomes of her entire family. And Miss Patricia Olenek, whose art exhibition in our Fine Arts Gallery entitled Reconceived Bodies in 3 Parts, offers us an artistic exploration into the medical, scientific, technological, and symbolic representations of both human and non-human life. Ms. Olenek is director of the Graduate School of Art and the Florence Bush Professor of Art at Washington University in St. Louis. Please join me in welcoming our distinguished guests. At this time, I would like to take a moment to recognize and thank all of our current as well as our retired Brown Chair holders. And I ask them now to please all stand and be acknowledged by this group. Would you all stand up, please? These are the people that make it happen. Thank you for your leadership. The last 3 decades have been extraordinary for Southwestern. Much of our recent success can be traced back to the support of the Brown Foundation, which in 1976 created a transformative 20-year challenge grant program that, more than any other single factor, resulted in the marvelous possibilities enjoyed by our university today. On behalf of the faculty, students, staff, trustees, alumni, and parents of Southwestern University, I am delighted to welcome you to this year's Brown Symposium. May you find the conversation stimulating, inspiring, and of course, healthful. Enjoy. Thank you very much.
Thank you, President Berger. Let me add my words of welcome. Welcome to Southwestern University. Welcome to the 36th Brown Symposium. I'm Ben Pierce. It's been my honor and privilege to help organize this year's Brown Symposium. Over 2,000 years ago, Hippocrates laid the foundation for modern medicine by basing the treatment of disease and diagnosis on empirical observation and reasoning. And in doing that, he really firmly rooted medicine in the tradition of science. At the same time, Hippocrates emphasized the art, or the human side of medicine, by teaching his students the importance of honesty and compassion, integrity and ethics in the treatment of illness. And today, medicine maintains this dual nature, being both an art and a science. In the early part of the 20th century, William Osler was professor of medicine at Johns Hopkins University, and he was one of the founders of modern medical practice. Osler also emphasized the art and the science of medicine. He said, the practice of medicine is an art based on science. He said, the practice of medicine is an art, not a trade, a calling, not a business, a calling in which your heart will be exercised equally with your head. Over the next day and a half, we're going to hear from 6 outstanding speakers and an artist about the art and the science of medicine. We're going to hear from some practicing physicians about the craft of medicine and about the tension between fast-paced, high-tech medicine and slower-based, more human-focused medicine. We're going to get a preview of some of the latest scientific advances that are altering the face of medicine today, specifically genomic science and nanotechnology, and how these are allowing treatment to be personalized. We're going to take a global perspective on health, and we're going to hear about some diseases and disorders that affect hundreds of millions of people around the world, and yet that are often neglected by our Western approach to medicine. And then we're going to also learn about what is perhaps the most significant issue facing medicine today, and that is how are we going to pay for it in the future. We also have an ongoing art exhibition entitled Reconceived Bodies in 3 Parts by Patricia Olnick. Her work explores medical, scientific, technological, and symbolic representations of both human and non-human life. Before we hear from our first speaker this morning, I wanted to take just a few minutes to provide some context for our symposium and to pose a couple of questions that I hope that we'll take at least a little bit of time to consider over the next day and a half. So first, let me make some observations about healthcare in the U.S. At the present time, we spend about $2.6 trillion every year on healthcare in the U.S. Not $2.6 billion, but $2.6 trillion. That comes out to an average of over $8,000 per person. Of course, we spend more than $8,000 on some people and less than $8,000 on other people. In terms of our gross domestic product, that's about 18%. So remember that our gross domestic product is our total economic activity. So out of each dollar of economic activity that we generate each year, about 18 cents of that goes to healthcare. And that percentage has been rising dramatically over the last 40 years. In 1970, we only devoted 7% of our gross domestic product to healthcare. Today, it's 18%. The economists tell us that in just a few years, it'll be 20%. The economists also tell us that we're on an unsustainable trajectory, that we cannot continue to devote an ever-increasing proportion of our GDP to healthcare. Eventually, it will bankrupt us. Interestingly, 50% of our healthcare spending goes to just 5% of the population. These are the most acutely ill people. And oftentimes these people are in the last year of their life. Now remember that I told you that we spend about $8,000 per person per year on health care in the U.S. Turns out that that's far more than anybody else in the world spends on their health care. In this slide, I plotted the per capita total health care expenditures for the U.S. and a number of other countries that have similar standards of living. And you can see that the U.S. is way off to the right compared to these other countries. As I said, we spend about $8,000 per person per year. Many of these other countries spend less than $4,500 per year. So if you live in the United Kingdom, or Sweden, or New Zealand, or Italy, or a long list of others, they spend less than half of what we spend on health care. And if you look globally, how much we spend on health care for people around the world, it's only about $640, whereas we're spending $8,000. Some people I know would say, well, it's okay that we're spending a lot more on our health care because we have the best health care in the world, and that's what we're getting for our money. So do we have the best health care in the world? Are we getting more for the money that we spend? Well, that was the focus of a study that was completed just a year ago. This study was carried out by the U.S. National Research Council and the U.S. Institute of Medicine, two nonpartisan, highly respected research organizations. What they did was they gathered together a team of sociologists and economists and scientists, and they asked them to compare health outcomes in the U.S. with health outcomes in other countries that were comparable. So they picked 16 other nations that are similar to the U.S. in standard of living and education, technology, and they looked at what are the health outcomes in those countries compared to the health outcomes in the U.S. The conclusion of that study is summarized by the title of their report, which I've shown up here on the screen. The title of their report was U.S. Health in International Perspective, Shorter Lives, Poor Health. That tagline was their conclusion, that in the U.S., in spite of spending almost twice as much as people in these other countries, people actually don't live as long and live in generally poor health. So let me show you some data to support that assertion. So one broadly accepted measure of health outcome is simply mortality rates. So in this slide are plotted the mortality rates for non-communicable diseases. These are non-infectious diseases. These are what most people in the U.S. die from: cancer, heart disease, stroke, diabetes. And what you see when you look at mortality rates is that we're second from the bottom. Only Denmark has higher mortality rates for these non-communicable diseases than does the U.S. Another broad measure of health outcome is infant mortality rates. And if you look at the infant mortality rates in these countries, we're dead last. We experience about 6.7 infant deaths for every 1,000 births. Many of these countries have less than half that. So if you live in Sweden, Japan, Finland, or Norway, the infant mortality rates are half of what they are in the U.S. People in the U.S. have higher rates of adverse birth outcomes, more heart disease, more injuries from motor vehicle accidents, more injuries from violence, more sexually acquired diseases, more chronic lung diseases. These are all indicators of our health, and in general, we do worse in these areas than people in these other countries. You can also look at mortality rates for specific diseases and disorders, and that's what's shown in this slide. It's kind of a complicated slide, but on the left are listed a number of medical conditions, causes of death. The shadowed first column are the average death rates in the U.S., and the second column are the average death rates in these other peer countries. And what you see is that for most of these conditions, we actually have higher death rates than people in other countries. So if you get one of these things in the U.S., you're more likely to die than you are in one of these other peer countries. So these include cardiovascular diseases, neuropsychiatric conditions, respiratory diseases, infectious diseases, diabetes, endocrine disorders, intentional injuries, unintentional injuries. For all of those things, we have higher death rates than people in these other comparable countries. The one thing that we do a little better at is cancer. If you get cancer in the U.S., you have a slightly higher rate of surviving than in these other countries, but it's just a little bit. For most of the other conditions, the death rates are higher in the U.S. or they're the same. So in spite of spending a lot more on our health care, we're not getting better overall health outcomes. The sociologists have referred to this as the American healthcare disadvantage. We don't like to think that we're at a disadvantage in the U.S., But in terms of these broad measures of health care, we clearly lag behind these other peer nations. Well, the question is, why do we spend twice as much and not get better health in the U.S.? Well, these researchers that did this report looked at a large number of factors that might explain this disparity in health outcomes. They looked at rates of poverty, rates of obesity, rates of drinking and smoking, lawsuits, a large number of other factors. And what they found was that while each of these things contributes a little bit to the disparity, none of these things fully explains the difference in health outcomes in the U.S. compared to these other nations. Here's a quote from the study. The author said, "Individual behaviors may contribute to the overall disadvantage, but studies show that even Americans with healthy behaviors, for example, those who are not obese or do not smoke, appear to have higher disease rates than their peers in other countries. The problem is not confined to socioeconomically disadvantaged Americans. As noted above, several recent studies have suggested that even Americans with high socioeconomic status may experience poorer health than their counterparts in peer countries." Now, let me add a couple qualifications. One thing to note is that one thing that we do better at in the U.S. is having rapid access to medical procedures, particularly high-tech procedures. So, for example, we have more MRI machines per person in the U.S. than most of these other countries. So if you need an MRI, you're more likely to get that done quickly in the U.S. than these other countries. We have more medical specialists than many of these other countries, and it's easier to see a specialist in the U.S. than in many of these other countries. And if you're over the age of 75 and you need a knee replacement, you're more likely to get that in the U.S. than in our peer countries. But in spite of the more rapid access to health care, particularly high-tech health care, that has not translated into these broad measures of health outcome. So one question that I hope that we'll take at least a little bit of time to talk about during this symposium is how can we make our health care system more efficient and more effective than it is? So I want to switch gears now and talk for just a minute about the changing nature of medical practice in the U.S. And I'm going to refer to this book written by Lewis Thomas. Lewis Thomas was a physician and a writer, a poet, a researcher. He died in 1993. I became familiar with Lewis because when I was a young assistant professor at Connecticut College, Thomas came and gave our commencement address in 1983. And it was one of the best commencement addresses I've ever heard. I still remember many parts of that today. So I began to read some of the things that he had written. He wrote this book actually in 1983, the same year that he came to Connecticut College. And in this book, he chronicles the changing nature of medical practice in the U.S. during the 20th century. His first exposure to medical practice came from watching his father practice medicine. His father was a small-town physician, practiced medicine in Flushing, New York, on Long Island, between about 1910 and 1930. Thomas points out that his father knew all of his patients personally. He not only knew their medical difficulties, he knew their families, he knew their occupation, he knew their standing in the community, he knew about all of their problems. He practiced medicine in their home. The family lived upstairs, he had his clinic and his office downstairs. But Thomas said his father didn't spend much time in the clinic. He spent most of his time making house calls. He went around and visited his patients in their homes, diagnosing their medical problems and treating them in their own homes. And when his patients became acutely ill, he sat up with them all night until they got better or until they died. Thomas points out that the reason that his father made house calls and the reason that his father stayed up all night when his patients were ill was that that's really all he had to offer them. This was a time before there were antibiotics or other powerful drugs. He had very little treatment to offer his patients that could really do anything for them medically. Diagnostic procedures were very crude. In many cases, he didn't even know what was wrong with his patients. So he offered them the only thing that he had, which was hope and compassion. Then Thomas himself went off to medical school. He went off to medical school in the 1930s and began his own medical practice, which extended through the 1980s. And this was the time in which medicine became infused with science and technology. Antibiotics became available in the 1940s, and antibiotics completely transformed medicine. These were miracle drugs. A physician might have a person who's dying from pneumonia, could give them or she could give them a few doses of penicillin, and they would be miraculously cured. Antibiotics were followed by other powerful drugs for treating diabetes and heart disease and hypertension, cancer, and eventually psychiatric disorders. And these made a huge difference in the effectiveness of medicine, what the physician really had to offer the patient for their illness. So Thomas talks about this transformation of medicine, what a huge difference science made. And he calls this the youngest science because science really wasn't introduced to medicine in a big way until the latter part of the 20th century. But Thomas notes that while medicine was being infused by science and technology, and while it was becoming much more effective, the human side, the art of medicine, began to be diminished. He notes that physicians no longer made house calls, not because they were lazy or less compassionate, but they didn't have access to the technology in a person's home. That was only available in the clinic or the hospital. They no longer sat up all night with their sick patients because now they had something tangible to offer them. Sitting up with a patient didn't help them get better. They could give them some drugs or a surgical procedure, which did make a difference. But nevertheless, Thomas says that something is being lost from medicine. He says, the close-up, reassuring, warm touch of the physician, the comfort and concern, the long, leisurely discussions in which everything, including the dog, can be worked into the conversation, are disappearing from the practice of medicine. And this may turn out to be too great a loss for the doctor as well as the patient. But Thomas also adds that there's no going back to the old days. He says, and who would want to go back? If you have a choice between a physician who has antibiotics and a physician who can only make house calls, who would choose the physician that can make house calls? So another question that I hope we'll take a little bit of time to talk about during the symposium is, does there have to be this separation or this conflict between the science and the technology and the human side of medicine? Does our use of modern science and medicine require that healing become less personal? Does it have to widen the gap between the patient and the healer? Is there an inevitable conflict between the head and the heart of healing? Well, again, I hope these are some questions that we can talk a little bit about. I'm really excited about the symposium. We have outstanding speakers. They're going to share a great deal of information with us about medicine. Healing and healthcare they profoundly affect all of us in personal ways, and they affect us at all stages of our life. And of course, healthcare is currently at the forefront of our national political debate. So I want to thank you for being here today, and I hope you'll be here tomorrow for the Brown Symposium. Really excited for the conversation that we'll all have about the art and science of medicine. Thank you.